This is the sixth in our series of 7 lectures in our radiosurgery course. I hope everybody's keeping up with the pre-tests and the post-tests you have to complete. Each one of you need to complete the pre-test and the post-test to pass the course. Our final lecture tomorrow will be on radiosurgery for malignant tumors, and then there'll be a final exam online, a non-multiple choice final exam that you'll need to complete, and once we have all those in hand, we will give you your grade and see whether you pass the radiosurgery course. So let's try to dot the I's and cross the T's here. Today we're talking about benign tumors. Some of you have heard me give this talk before at Steve Lewis's course. I've added in a little bit of information on meningiomas. But just to refresh your memory, the paradigm is as follows. The patients are seen on Monday afternoon jointly with radiation oncology. If it's determined that it's appropriate for them to get radiosurgery, they stay in the hotel, and then they're treated starting on Tuesday morning with head ring application under local anesthesia. Everybody gets a CAT scan from the top to the bottom of the localizer. They've already had a volumetric MR. That's done on Monday. And we do that non-stereotactically, that is, without a stereotactic frame, to avoid any distortion of the MR scan that can be induced by the frame and by the localizer. We fuse that with software to the non-distorted frame stereotactic CT scan that's done on Tuesday. Dose planning we spent a day last week looking at. We use sphere packing. It's a little tricky and requires some practice, but the goal is not tricky. The major goal is conformality. We want a dose plan that's conformal to the shape of the tumor, and the secondary goal is dose gradient. We want to maximize the dose gradient so that within 3 to 4 millimeters of the prescription isodose, we're down to half the prescription isodose. So this is an illustration of sphere packing for a vestibular schwannoma. And here is a typical vestibular schwannoma with both the CP angle component and the intracanalicular component. You really shouldn't treat that with a sphere. So in this case it took 3 or 4 isocenters. The red line is the 70% line, which is the isodose line you'll recall that we use for multiple isocenters. And the green line is the 35% line, or half the treatment prescription line. So it falls off very rapidly to a harmless dose. Now, dose planning is actually a lot more similar to flying my airplane than to doing neurosurgery. This is a picture of the cockpit of a Cirrus SR-22. Greg Murad's been trapped in there for a few hours in the past. Kelly Foot's taken a ride. Anybody else, you're welcome anytime. But this plane is completely computerized. Frank's been with me. And all the traditional instruments are replaced with computer screens. But as you can see, there are lots of buttons to push and knobs to turn, and you need to practice so you can get the right buttons and the right knobs sort of without thinking about it in the right order, or you could have a problem, especially if it's like you're flying through the clouds trying to break out with the runway in front of you, not a tree in front of you. So radiosurgery planning is a little bit, it's not really like anything you learn in the operating room. Now here is a group of patients a few years ago. We treat up to 12 new patients every Tuesday. And once the head rings go on, they get the scans. While we are doing the computer planning, they're having breakfast with their families. And then one at a time, they're connected to the radiosurgical machine. Now this is the original prototype machine that Frank and I worked on for a couple of years in the late 80s, and Frank built in the machine shop here at Shands Hospital. You can see the plywood over here. This is truly a prototype. This machine eventually went to Israel, where it was used for a couple of years by my fellow Roberto Spiegelman in Tel Aviv. This is the Philips commercial version of the machine, which came out in 1991 and was one of the early commercial linear accelerator radiosurgery systems. And this is the current commercial partner that we have, Varian. Varian owns about 80% of the linear accelerator world, so they're a good partner to have. As I've explained before, this machine, which is called the Trilogy machine, includes an inline cone beam CT scanner so that we can expand radiosurgery from the brain, where we use a stereotactic frame, to the body, where it's really not practical to use a stereotactic frame. And this machine, as well as others like it, made by other manufacturers, is being used to treat, using the radiosurgical paradigm, treat tumors in the liver, the lung, the prostate, and the pancreas. So as you remember from the history talk, it's only recently, maybe in the past 5 years, that radiation oncology, as well as other specialties, have gotten serious about using radiosurgical techniques to deliver very high doses of radiation to localized malignant tumors, for example, lung tumors, with very good results as long as they catch them early before they've spread to the lymph nodes or other parts of the body. So, and a reminder, this is a very, very accurate technique. This is a trigeminal nerve after radiosurgery for trigeminal neuralgia. And you can see the nerve is enhancing. That's a 5mm shot. We can't achieve that kind of targeting precision. We have to be able to achieve that. In this case, we delivered 9,000 centigray in a single dose. So if you miss with that, you're going to leave basically a hole in the brain wherever you concentrate that dose. So here are some before and after shots. I'm just going to quickly show you some before and after shots of vestibular schwannomas, and these are all 10-year plus follow-up. So here's the treatments, and here's 10 years later, and you can still see an abnormality here, but as is typical for this treatment, the tumors slowly shrink over time. And we think that this remnant, 10 years plus, is dead. It's scar. It's extraordinarily unlikely to cause any problems for the patient. Here's another one. This is a tumor that also had a cyst associated with it. People ask me, if there's a cyst, isn't that a contraindication for radiosurgery? And in general, I don't think so, because the cyst is not generally a tumor cyst. It's an arachnoid cyst. And it's an arachnoid cyst that's caused by disruption of normal CSF flow in the vicinity of the tumor. And if you can shrink, you get rid of the tumor and the cyst goes away also. Here's another one. And here again, the typical, it doesn't go away. The only way to make it completely disappear is to operate, but it typically shrinks. We really don't care if it, as long as it doesn't grow. That's a success, because these patients in general are having minor symptoms, hearing loss typically, but maybe some imbalance or tinnitus. And if we can prevent the tumor from becoming bigger and causing significant symptomatic brainstem compression or other problems, then it's basically equivalent to a cure without the risk of surgery. Here's another tumor. Here's the after shot again, the shrunken remnant of the tumor. So this, as of about 6 months ago, I think we had treated 525 vestibular schwannomas. This age is a little older than the average presenting age for vestibular schwannoma, probably because at the beginning of our experience we tended to operate on the younger patients, and radiosurgery was the option for older patients. Although 62 isn't looking too old to me today, actually, but the volume average is 2.1 cc's. Again, remember, radiosurgeons think about volumes. Neurosurgeons, we typically think about diameters. but we're thinking about volume. The magic dose, the right dose for vestibular schwannoma is 1250 centigrade. That's the dose that fortuitously produces very high tumor control and very low risk of cranial neuropathy. And most of them are going to take 2 isocenters, but depending on their complexity, especially if they've had prior surgery, you may need multiple isocenters. And as you can see, the median follow-up period is quite long on this group. So most of them present with hearing loss, others with unsteadiness. A few present primarily with hydrocephalus. And that can be obstructive hydrocephalus, but more typically it's communicating hydrocephalus, probably caused by protein shedding from the tumor. And then, of course, neurofibromatosis, too, is characterized, it's basically defined by the presence of bilateral vestibular schwannomas. So, indications for radiosurgery, these are sort of old. At the beginning, we felt like we had to have a reason not to do surgery. So failed surgery is a good reason. Medical infirmity is not a very good reason because usually if patients are medically infirm, we don't treat their benign tumors at all if they have other diseases that are going to be life-limiting. Age greater than 60, certainly the risk of anesthesia goes up with age, although again, I think 60 is probably too young. We do a lot of trigeminal neuralgia surgery in late 70s, early 80s. It's actually easier, and in a sense, even the vestibular schwannoma surgery will be easier because the atrophy of the cerebellum makes it easier to retract and get to the tumor without any significant pressure. So this is an early paper that Kelly Foote wrote when he was doing a lab here with me back in 2002. And at that point, we had a 90% 4-year actuarial control rate. And we had a low but real instance of facial neuropathy. And it was at that point that we did a statistical analysis that suggested that 12.5 gray was the right dose. And that paper really influenced the practice of radiosurgery worldwide, because up till that point, people in general were using higher doses. Somehow the word came from Sweden that 20 gray was the right dose, and that, I can tell you, that dose will produce facial palsy 100% of the time. So we still don't quite understand how there was an error in translation there, I guess. So here's a later paper that we put together on our vestibular schwannomas. It was on our first 390 patients. And you can see that 90% of the time there is actuarial tumor control at 5 years. I think there are 2 important takeaway messages here. One, 99% of the patients that we've treated with radiosurgery have never required any other surgical treatment. And what that means is that if they did have some tumor enlargement, it almost always was very minimal, non-symptomatic enlargement, which we just continued to follow, and the enlargement sort of stabilized. The other important message is that since we reduced the dose to 1250 centigrade in 1994, the cranial neuropathy rate has been less than 1%. We still occasionally will get a facial nerve, but it's very, very rare. So now we looked at treatment plan quality. Richard Beagle was one of our medical students a few years ago who wound up going into radiology. We did this study. We looked at the same 390 patients. And remember, early on, we were just using CT scans and single isocenters. Later, we were using MR and multiple isocenters. And this paper was a little disappointing, but the message is important. The dose, not the dosimetry, in this particular tumor was the overwhelmingly important factor. So even if you include a lot of non-tumor tissue, most of that tissue is temporal bone, and that was not important in producing cranial neuropathies. what was important was reducing the dose to 1250 centigrade. Now, I think there might be one exception to this. We didn't look at hearing preservation in this series, and there are some papers out there that suggest that the 4-gray dose to the cochlea may be predictive of hearing preservation. It's pretty hard to keep the dose. Let me put it this way. If the tumor goes all the way out to the end of the internal auditory canal, you cannot reduce the dose to the cochlea to 4-gray. It's not possible. But if the tumor doesn't go all the way down the canal, which happens maybe half the time, then you can keep the dose down, and you might be able to have a better chance of preserving hearing. But facial neuropathy and trigeminal neuropathy are not dependent on conformality. They're dependent on dose. Just like I showed you for the arteriovenous malformations, if you look at groups that have done fairly significant numbers of vestibular schwannomas, the results are the same. And the only groups that haven't done big numbers are the LINAC groups. The Gamma Knife series account for the vast majority. But as I told you, we've done over 500. Our results are identical to the results from Pittsburgh. It really is not a matter of what machine you have. It's a matter of experience, dose planning, correct dose selection, correct patient selection, careful patient follow-up. All right, now, the big kerfuffle is always about, well, what about surgery, And, the message that I'm going to give you is that surgery for small vestibular schwannomas is obsolete. I mean, it should not be done if you care about your patient. If you don't care about your patient, I guess you can do anything you want. And here, I'm going to explain why. Here's the best neurosurgical series in the world, vestibular schwannoma series, Majid Sami's series of over 1,000 cases. And if you look at complications, close to 9% CSF leak, you all know how bad caudal cranial nerve palsies are. I mean, you're buying a tracheostomy and a feeding tube for at least a couple months. Symptomatic hematomas, hydrocephalus, meningitis, I mean, these things happen after the best possible surgical procedure. It's not the surgeon's fault. These are just risks of doing surgery. 45% facial nerve paralysis, medical complications, which we all know occur, not mentioned, and most importantly, there is no surgical series out there that tells you what their long-term actuarial control rate is. We know it's not 100% because I already showed you that a quarter of the patients we treat with radiosurgery are failed surgeries. So here is a Al Roten cure, okay? A patient who is operated on. I think Dr. Roten is as good a vestibular schwannoma surgeon who's ever walked the earth, and a remarkably good surgeon at preserving hearing, preserving the facial nerve. This patient was operated. This patient was lost to follow-up. This patient came back with a big recurrence. It happens all the time. Here is the neurotology literature. The very best neurotology experiences at the House Clinic in Los Angeles. Daryl Brackman is the most famous neurotologist around. These were big tumors. Again, they didn't report their cure rate. They don't know what it is. But they did say that in 4% of the cases they were not able to remove all the tumor. They also had a 45% facial nerve palsy rate with a lower rate of CSF leak, meningitis, other complications not reported. And here are small tumors. These are all tumors that were removed via the middle fossa approach. So these are all basically intracanalicular tumors, 106 of them. Again, cure rate not reported. Total tumor removal estimated at 98%, and they still had an 11% facial neuropathy rate. So best possible surgery, small tumor, the cranial neuropathy rate is over 10 times higher with surgery than with radiosurgery. End of story. Okay? The best surgeons simply cannot do what radiosurgery can do in preserving the facial nerve. So If you look at other symptoms, ditto. Every single series shows that patient satisfaction, tinnitus, dizziness, pain, you name it, they're better after radiosurgery than they are after surgery. So, this Buddhism stuff, it's really good, especially if you're a resident. So, because basically, Siddhartha showed us that all is suffering, all life is suffering. Suffering is caused by ignorance. The cessation of suffering can lead to nirvana, the end of samsara, and the eightfold path to nirvana is the path of renunciation. And of course, we ask you to renounce anything worldly during the 7 years that you're with us as neurosurgical residents. Now, here at the University of we need to talk about the 4 ignoble untruths that are propagated by the evil neurootologists about radiosurgery, and sometimes even my own partners. Untruth number 1, acoustics rarely grow, so radiosurgery results are just the natural history of the tumor. Number 2, radiosurgery makes subsequent surgery harder. 3, we don't have any long-term radiosurgery data. And 4, radiosurgery causes cancer. So, if you want to know about the natural history of radiosurgery, you can check out this chart on the Moodle site. There have been a few studies published since then, but they all basically add up to the same thing, that even though the follow-up period is relatively short, it's less than 5 years in all of these series, that the majority of the tumors did grow on follow-up. The growth rate may be slow, and it may be particularly slow in elderly patients with intracanalicular tumors, or possibly small tumor remnants after surgery. They may be devascularized, and they may not grow as rapidly. But the bottom line is these are tumors. Tumors grow, right? That's how they got to be tumors, that you can see. And they're going to continue to grow given enough time. So we did have the opportunity to look at this rare group of patients with bilateral vestibular schwannomin. And Jay Vakani did this study during a summer medical student project a few years ago. Basically, we had 13 patients, and we treated one tumor. We didn't treat the other one. You usually don't treat both sides. You treat the side where the patient's deaf, usually, and you let the side where they can hear, we let the tumor grow until the hearing is gone, because that may take years and years. We look at the patients. These are their characteristics. And in the treated tumors, the actuarial tumor control rate was 92% at 5 years, just like our non-neurofibromatosis group. 7 tumors shrank, 5 remained the same size. And so there's the Kaplan-Meier plot of tumor control. In the untreated group, okay, so this is a natural control, the tumor control rate was 21% at 5 years. None of the untreated tumors shrank, although that can happen. 6 tumors remain the same size. And so there's the Kaplan-Meier plot. Here's an example. This is the kind of ugly situation you get into with these patients. But this tumor is this is about 3 months after we treated this tumor, and that was in 1989. And now in 1995, this tumor has continued to shrink, and this tumor, of course, has continued to grow. And this sort of is, if you don't believe that the radiosurgery results are different than the natural history of the disease, I think this is an interesting way of looking at that problem. So, conservative follow-up is fine, and we do conservative follow-up on elderly patients, especially if they have a lot of medical comorbidities. If you think that the patient's lifespan is going to be limited, such that the tumor is unlikely to grow to the point where it will cause serious problems, then you shouldn't treat the patient. You should just follow them. But you need to follow them, because they will grow. And so here's a patient who was seen in 99, and then like 6 or 7 years later she came in, and now her tumor was at the upper limit of what we would typically treat with radiosurgery. Here's another case where the tumor, of course, continued to grow, and you need to impress upon these folks that if they're not going to be treated, they should be scanned once a year. For a variety of reasons, patients don't comply with follow-up. They may lose their insurance, they may move, they forget, they get distracted by other problems. Who knows? But conservative follow-up has actually been looked at in a neurootology study, and you get about a 50% compliance rate with a large group of people that you're trying to follow conservatively. So what about the surgery after radiosurgery thing? Well, you know, if 99% of the time you don't have to do surgery after radiosurgery, you're not going to have the opportunity to evaluate this question very often. So I've operated 5 times on 500 plus patients, and I personally thought it was easier because the tumors were very avascular. Okay. Others report that it's harder because of scarring. And I think basically if you look through the small number of case series in the literature, you're going to find out that the people who hate radiosurgery report that it's harder. And the people who like radiosurgery report that it's the same or it's easier. And that's the current state of our scientific evidence on this particular question at this time. Now, what about long-term results? Well, we do have good long-term follow-up. There's a Japanese series of 80 patients followed from greater than 10 years. And then Kanzioka series, which continues to, it's over 1,000 patients now, not all followed for 10 years, but again, in their series, 98% of the patients required no further treatment. In our series, it was 99. Their total facial neuropathy rate was 5%, but remember that included a lot of patients who were treated early on with a dose that was greater than 1250 centigrade. Since they've gone to 1250 centigrade, they have achieved a 0% facial neuropathy rate. And I just want to remind you one last time that there are no surgical data on this question. I mean, the surgeons assume that when they operate, the patient's cured, and we know that assumption. I mean, when I operate, you know, I cure my patients 100% of the time too. So I understand it, okay? But it is, you know, for the rest of you, you're not gonna get 100%. It just ain't gonna happen. Okay. Now, what about radiation-induced malignancy? Yes, radiation causes malignancy. I mean, Steve Roper uses radiation on fetal rats or mice to induce hamartomas, right? So radiation will cause tumors. The biggest experience in the literature is actually the use of radiation therapy in Israel for tinea capitis. Okay, so there used to be a kind of radiation that your pediatrician could give you in their office called Grentz ray radiation. I don't know if you guys remember going. You're all too young for this, but when I would go to the pediatrician, he had a fluoroscope in his office too, which was probably irradiating everybody within miles when he turned it on. And actually, you used to be able to go to the shoe store, and they would x-ray your feet in the shoe store to see if your foot fit. Do you remember that, Steve, or not? Too young? Yeah, but Gwen, you remember. Okay. All right, well, okay, so back in the, 50s, a lot of Israeli children got treated with these very short-range radiation devices for fungal infections of the scalp, and they turned up 20 years or 30 years later to have a high incidence of meningiomas. A lot of them were atypical meningiomas. And then we know we all have patients who were irradiated for a pituitary tumor, and then 20 years later they turn up with a temporal lobe glioblastoma. Or they were irradiated for a medulloblastoma in childhood and cured, but now they have a malignant glioma or a bunch of meningiomas. We all have patients like it happens. Now remember that most of those radiation fields were very big radiation fields. I mean, many of them were just an AP port and a lateral port. That was it, with a huge margin added on. A lot of them were craniospinal radiation. The entire nervous system was irradiated. So yes, those kinds of treatment seem to be associated with a 1 to 2% risk of delayed tumor induction, some benign, some malignant. But radiosurgery and actually modern radiation therapy fields are much, much smaller, much more focused, and should therefore have much less risk. And right now there are 5 or 6 cases in the literature of documented post-radiosurgery malignant tumors, where there was a benign tumor to start with, and 1 case involves a vestibular schwannomin. I've got details on this on the website. There are every case in the literature, not just these 6, but tumors where another malignant tumor turned up, where a different malignant tumor was present, or the patients had a genetic predisposition towards developing malignancy. And there are also cases where there was no radiation and vestibular schwannomas spontaneously degenerated into malignant tumors. All right, so just a reminder that your chance of being killed by a lightning strike is greatest in Florida out of all the states in the United States. It's because we have thunderstorms almost every afternoon, especially in South Florida. And your risk of a lightning strike death is 1 in 100,000, okay? The risk of a radiosurgically induced malignant tumor is at the very greatest 1 in 1,000. It could be as low as 1 in 100,000, like a lightning strike. But we won't argue about that. Let's say it's 1 in 1,000. What's the risk of dying from a craniotomy? Well, it's a lot more than 1 in 1,000, and it has nothing to do with the skill of the surgeon. 1,000 perfectly performed operations. Some of those patients are going to have a heart attack and die. Some are going to have a PE and die. Some of them are going to have a seizure and status or something like that and die. There are a lot more than 1 in 1,000 deaths from craniotomy for brain tumors. So you need to put the potential risk of a radiation-induced malignancy into perspective. It is a very, very small risk compared to all the other complications of surgery that I presented to you from the Sammy and Brackman series, and that we have to deal with every day on rounds here. All right, so here, we've written a few articles, and these are, some of these are included in the Moodle module. All of them are available through PubMed. Here's the Beagle study I mentioned before. Here's the Vicani study. This is a mathematical analysis of the complication probability after radiosurgery. Here is an early series with Bill Mendenhall and John Buati. Kelly Foote's paper. A more detailed analysis of risk factors. This is where we came up with the 1250 dose. It was in 2001. The more recent publication on the first patients. Now, a few words on meningiomas, and the message is basically the same for meningiomas. The results, the indications are pretty much the same. The results are pretty much the same. We've treated close to 500 meningiomas with radiosurgery. The tumors are a little bit bigger. The patients are a little bit younger. The magic dose is still the same. The indications listed here, again, medically infirm patient, we usually don't treat at all. So these are the locations of the meningiomas, and I think at this point, I believe we're getting close to 100 cavernous sinus meningioma locations. But here's a typical before and after shot. This is a patient who had a venous malformation up here, but she has a small falcine meningioma. She's in her 40s, I think, and we could operate on that. But it's the same tumor, 5 years later, shrunken, scar, probably never going to grow again, outpatient treatment, no risk. Cavernous sinus meningioma, I think, it's hard to believe, but we actually lived through an era where cavernous sinus meningiomas were being enthusiastically operated on by Sam Al-Mefti and Laligam Shaker and John Tu and other virtuosos of skull-base surgery. I mean, the bottom line is you get a 0% cure rate with surgery, and you get a 100% complication rate. I mean, it's close to that. You've got cranial nerve 3, 4, 5, and 6. You've got the carotid artery, and you've got a very challenging venous plexus to deal with. And so this is an area where you might do a biopsy to see what the histology is, but if you're in your right mind, you're not going to do surgery. And it is a typical result. We've had great results with cavernous sinus meningiomas and radiosurgery. We published a paper on that. Unlike surgery, we actually see patients whose cranial neuropathy improves after treatment instead of deteriorating. So this was a paper, I think that guy Murad, wrote this one. Back in 2005, it was our first 210 patients with a 96% 5-year actuarial control rate. Now, that's for benign tumors. Atypical tumors do not respond as well to surgery or conventional radiation or radiation. And malignant tumors are basically a fatal disease. They don't respond. They're like trying to cure glioblastomas. They're almost that bad. Now, we did have some temporary radiation-induced complications. All of the patients who experienced a permanent radiation-induced complication in this series had malignant tumors. So remember, they had not only had radiosurgery, they had conventional radiation therapy and surgery and then radiosurgery. And so they were certainly at higher risk for complications. We haven't had any substantial complications in the benign. So these are the Kaplan-Meier control rates: benign tumor, atypical tumors, malignant tumors. All right, so here is the Kimball paper published in 2009 after about 2 years of revisions. But you'll see that the actuarial local tumor rate in this group of patients was 100% at 5 years and 98% at 10 years. And 65% had improvement in their cranial neuropathy. Only one patient was worse, and I think that was a facial numbness complaint. So that's a superior result compared to what can be done with surgery. Here, a general review of meningiomas. Dave Shaffron, some of you ran into Dave at the AANS meeting in Denver. He is currently a pediatric neurosurgeon in Phoenix. Here's the Murad paper from 2005. Another Mendon oncology paper. So again, we started this May 18th, 1988. We've had patients, and I can't convince everybody, but I think that the scientific evidence is extraordinarily compelling that vestibular schwannomas and meningiomas that are in the size range, which is safely treatable with radiosurgery, and that generally is 10 cc's or less. Sometimes it's bigger. I mean, I can't possibly produce the kinds of results with surgery that I can with radiosurgery, and I don't know anybody who can, and I haven't seen any publications that demonstrate that there are other surgeons out there who can. So skull-based surgery is great. There are plenty of big tumors out there that we can't treat with radiosurgery that need skull-based surgery. But the small tumors, this is the way to go. Again, if you read the literature, if you study it, if you care about the results, this is the way to go. So I believe that radiosurgery as currently practiced provides tumor control, complication rates which exceed even the most experienced surgeon's capability. think radiosurgery is the treatment of choice for vestibular schwannomas and meningiomas that are less than 2.5 centimeters in diameter. Microsurgery by an experienced acoustic surgeon is the treatment of choice for bigger tumors. And you got to get over this sort of egomaniacal view of the world that surgeons get after they beat themselves up learning how to be neurosurgeons for decades. You have to be a doctor who is through with the love affair with this technique, who recognizes that he has played Narcissus, raining kisses on a mirror, and who now, out of the impacted masses of his guilt, has expanded into self-doubt and finally into the high state of wonderment. Thank you. Any questions?